take away the dilutional fact. Well, that dilutional fact is based on the amount of sugar you got floating around and how much that sugar pulls in the fluid that dilutes your sodium. Does that make sense?
So you're just talking about intravascular.
This is intravascular.
Not intracellular.
This is all intravascular, right? But it's relevant for this reason and this reason only. Everybody used to focus on osmolality as the big reason for the fluid shifts that causes cerebral edema. But one thing that has come up in study after study after study is if your serum sodium doesn't correct appropriately with your management, and even more so if you give fluids and you give insulin and your serum sodiums go down instead of go up, you're at risk for cerebral edema. You're at greater risk, right? So one of the management components to this, as I mentioned in the beginning, right, were these electrolyte imbalances. 10 minutes. So sodium is one of them, and its link to cerebral edema is huge. So it's important to follow it. And if you pull our CPG for the institution, we follow Q4-hour sodiums very, very early. And our colleagues in the ICU are very concerned about that as their surrogate measure for cerebral edema. Yeah?
So how fast do you drop the glucose?
That was the second question, right? So the general consensus is you want to drop, once you institute insulin therapy, it should be at a rate, so it's generally started at a rate of 0.1 units per kilo per hour. The uber young kid, less than 2 years of age, our endocrinologists really promote even halving that and going to 0.05 units per kilo per hour because they're so insulin naive, okay? But the ultimate rate is 50 to 100 mg per deciliter per hour. So if you come in and you got a sugar of 600, you get your fluid bolus, and at time 0 you start your insulin drip. In an hour, you'd like it to be about 500 or 550. An hour later, 500, 450. Okay? You don't want these precipitous drops because that causes greater fluid volume shifts. Once you get to about 300, one of the management things that we think of, or that we do, that may not seem very intuitive, but the kid still has a glucose of 300, and what do? We add dextrose to their volume, so their fluid. We add sugar. Why? Because, remember what I said earlier, you want to correct for volume depletion, you want to correct for hyperglycemia, but you also want to correct for acidosis, okay? You need sugar around for insulin to act on to push the hydrogen ions back into the intracellular compartment. It needs that vehicle. You need the substrate. The insulin acts on the glucose faster than it does act on the hydrogen ion. The rate at which you correct your hyperglycemia and your hyperacidemia is not the same. Okay? So you need to give that substrate around, right? And you want to keep them at about 200 to 300, because that's at a level where you're going to turn on your counter-regulatory hormones, your glucagons, your cortisols, right? And you're not going to break down fat anymore and get your ketone production, even though you're still hyperglycemic. Okay, does everybody understand that? You add that dextrose to your volume so that it gives something for the insulin that you continue to supply, something to act on, and slowly you'll start to correct the acidosis. And as you correct your acidosis, you close your gap. If you close your ion gap, you can stop your insulin, and you can transition them to sub-Q. That's usually the kid who's volume repleted, who has a closed gap, who can start eating their carbohydrates, and you can supplement them with subcutaneous insulin. Does that make sense? There's only one other thing that I wanted to mention in terms of the therapeutic endeavors, and then we'll just take some last minute questions. You get a kid that comes in and their pH is 6.9, 7.0, profoundly acidotic, their K is elevated, and maybe, let's say in the first scenario, they're hemodynamically stable. Do we give them Bicarb? Bicarb has been directly associated with worsening intracerebral edema. Absolutely under strict instructions to avoid giving Bicarb. That being said, there are two scenarios when you have to give it, right? One of the things that can happen is if you've got a whole lot of hydrogen ion floating around, what else do you have floating around? Potassium. Potassium and hydrogen like to sit together, okay? So we want the potassium in the intracellular compartment, okay? But our ketoacidosis has pushed it into the intravascular compartment. So if you get a kid who has a serum potassium sitting at the 5, 6, 7, 8 range, right? What are they at risk for? Cardiac arrhythmia. That kid can die from a malignant arrhythmia. So that's when we get EKGs on our patients. If you have profound hyperkalemia, right, and they're at risk for a malignant arrhythmia, the mainstay of therapy in that kid is Bicarb, because it protects the myocardium. At that point, I'm more inclined to protect the heart than I am the brain, right? Then there are the other modalities that we can use to correct the hypoglycemia, or the hyperkalemia, which just for all cases of hyperkalemia, right, what's one of the measures that we use to treat? Insulin and glucose, right? So your insulin's going to help drive that potassium ion back into the cell where it belongs. Okay? The other situation is if you have hemodynamic instability that's refractory to inotropes. So the sickest kid that I've ever had in my career, I had about a month ago. Some of you in this room were here with me. And she was a 14-year-old girl who was found in a pool of her own vomit next to an empty 2-liter bottle of Coke. And she had a GCS of 3. She was Kussmalling and had blown pupils. And I can't smell ketones, but there's a lot of people in my department that can, and they're like, that's a diabetic, because she reeked of it. She had a glucose of 1,000. She had a pH of 6.8. And I looked at her right when she came in, and I thought, this girl's going to die in my arms. She got aggressively resuscitated by us, to a great team of people. She got mannitol, which is something that you need to know. If she had profound cerebral edema, when we got her CT, her ventricles were slammed shut. She was acidotic, so we slammed her with insulin, slammed her with some volume, did not hyperventilate her, but we hyperventilated her at her own rate so that we kept her PCO2 at the same level as it was when she came in. That's very important, because if you hyperventilate, you increase your cerebral flow, thereby increasing cerebral pressure, thereby risk of herniation goes up. I didn't think she was going to make it. She was intubated. She was volume resuscitated, and we got her to the PICU, and I thought she was going to end up in a persistent vegetative state. And about 2 weeks later, I was sitting in the pharmacy getting a prescription for my kid for amoxicillin, and I look over, and the mom was standing right there. She kind of looked, she looked again, and then she turned and she ran and she hugged me, and she said, "You saved my daughter's life." And she walked out of here. So we do pretty remarkable things, right, in pretty dire situations, but you have to really understand what the pathophysiology of what's going on is, because it really impacts how you manage them. Yes?
In regards to that case, so when she came in, was she hemodynamically stable or instable?
No.
Unstable, so did y'all give the volume and then give the mannitol?
She got the mannitol first because she was herniating in front of my eyes.
Okay.
Then she was intubated. We manually pushed our volume, and she got it pretty quickly because at that point she had already had the mannitol on board. And then she started her insulin. That was the last thing that we did.
Hard to figure out like what ratio of volume you have to give the mannitol because they're going to lose it. But I guess if it's like emergent, just give it.
It causes an osmotic diuresis, but not that fast.
Okay. And then did
Because
you?
you're
So
going to
when
get volume shifts in the brain first. Basically what you're trying to do is quickly pull off any extra volume that's in the intracranial compartment to the intravascular compartment. You want to make her hyperosmolar.
And then for when you, so she was intubated.
She was.
And then so did y'all, do you choose to like paralyze her or not paralyze her so that she can breathe her on her own?
So she was moving, and that's why I chose to paralyze her, even though she was obtunded, because I didn't want her self-extubated more than anything else.
Yeah.
But the reality is she did get rapid sequence intubated, but if you have somebody who's obtunded, you don't necessarily have to do that. She had some purposeful movements, and that sort of impacted her management a little bit more. Any other questions?
What is the mud piles?
Mud piles is a mnemonic for all the different causes of anion gap metabolic acidosis. Yeah.
So you guys are, sorry, my voice. When do you potassium supplement? Because although their serum potassium is elevated once you're giving sugar and insulin, all of that's going to go back into your cells, and they're going to be at risk for
Yeah. So there's two answers to that question. There's an institutional answer, and then there's the right answer. The right answer is you do it after your first bolus and when you start your insulin. Because as soon as you start your insulin, remember these patients are actually total body potassium depleted, even though their serum concentrations may be elevated. So as soon as you start insulin, you're going to start to push potassium into the intracellular compartment, and you're going to start to lower your serum potassium. Now, we much rather tolerate low potassium than high potassium, but you do get to a point where if you are at low potassium, you can have some pretty significant problems. And some of these patients are total body depleted to the extent where even up front, they're hypokalemic. And if they are, you have to replete them earlier. It can cause flaccid paralysis, coma, apart from the myalgias and stuff that we classically think of. So the right answer is as soon as you start your insulin, you should replete them with potassium. Institutionally, we often will start insulin in the ED, but we don't like to add potassium to our volume fluids there, so they usually start it when they get to the floor. Thank you.
Thank you.
I warmed you up.
Ooh, I like this having chairs down here.
Oh, it's great.
Like two,
I know. I was gonna join you. Yeah. Oh, good.
I know.
Everybody like it? Was it good?